Good morning and afternoon, everyone. Thank you for joining us for this webinar, Evidence to Support Safe Return to Clinical Practice by Oral Health Professionals in Canada during the COVID-19 pandemic. My name is Greg Penny. I'm the Director of Programs of the Canadian Public Health Association, and I use the pronouns he, him. I would like to acknowledge that I'm located on the unceded original territory of the Algonquin and Anishinaabe people. They have been guardians of this land for millennia, and CPHA is grateful for the example their stewardship provides. CPHA is committed to working with all First Nations, Inuit, and Métis people and their governments in realizing meaningful truth and reconciliation. We have people from across Canada participating today, and I would encourage you to use the chat to identify the land which you're located on. In terms of housekeeping, we've all used Zoom. There's a number of functions along the bottom. You can change your view in the top right. We are recording this webinar and it will be posted on CPHA's YouTube channel. After this, once it's posted, we will send a link to everyone who is registered along with the slides from the presenters. We are using the chat feature and the Q&A feature for today's webinar, so please post your questions there. Just remember that the chat is not anonymous, so we can see if you'd like to ask an anonymous question, please use the Q&A. I would like to introduce our moderator for today. Dr. James Taylor is the Chief Dental Officer of Canada, located within the Public Health Agency of Canada. Dr. Taylor's role in the federal health portfolio and indeed across the federal government is to work with key public and non-public elements of the Canadian health community, and indeed our global counterparts, to advance population health, population level oral health through health promotion, disease prevention, and professional technical guidance with an emphasis on vulnerable populations. And with that, I will turn it over to Dr. Taylor.
Great, thanks very much, Greg, much appreciated. And thanks to CPHA for its ongoing support of oral health in Canada and for this particular platform to discuss this work. I'm going to start off by introducing our panelists. I'll start with Dr. Paul Allison, who is a professor at the Faculty of Dentistry at McGill University. Dr. Allison's research interests concern evaluation of clinical and other interventions aimed at improving oral health among patient groups, plus health service and population level interventions to improve oral health care, and health policies. His particular area of research interest is understanding barriers to accessing dental care and how to overcome them, including training dental and other healthcare professionals in ways that help improve access to dental care. Next is Dr. Carlos Quinones, who's Associate Professor and Graduate Program Director for Dental Public Health at the University of Toronto Faculty of Dentistry. Dr. Quinones' research explores the history, politics, and economics of dentistry with a focus on social equity. He is cross-appointed to the Dalla Lana School of Public Health at the University of Toronto. Next, I'll introduce Dr. Leah Rock, who's Director and Assistant Professor, School of Dental Hygiene, Faculty of Dentistry at Dalhousie University in Halifax. Dr. Rock is cross-appointed to the Faculty of Medicine, Department of Pathology. She also holds the appointment of scientist at the Beatrice Hunter Cancer Research Institute and is a scientific affiliate at Nova Scotia Health, Department of Anatomical Pathology. Her research focus on biomarker discovery that will advance early oral cancer detection and identify effective intervention strategies to reduce the number of individuals with aggressive advanced stage disease. And finally, I'll introduce Dr. Walter Sequeira, Professor and Associate Dean, Academic, University of Saskatchewan College of Dentistry in Saskatoon. Dr. Sequeira leads the Salivary Proteomics Research Laboratory. His program in proteomics, diagnostics, and therapeutics using saliva is unique in Canada. His research focuses on how saliva and salivary components can be used to improve patients' health, both in the diagnosis and as therapeutics. Next, I'm going to set the stage here a little bit with regard to how this particular project started off. And just to give it a little context, here we go. Marvelous. So first, again, to set the stage, maybe not everyone watching today is from the oral health community. 6 regulated professions in Canada, 13 regulatory jurisdictions. Important to understand that, each responsible, of course, for for the practice and patient safety, practice of dentistry and patient safety in their respective jurisdictions for their respective professions. And the background, you all remember that in March 2020, the oral health professions went back to effectively restricted practice, restricted to urgencies and emergencies. And then in May 2020, a gradual return to practice. Now, this was different, as you might imagine, across all jurisdictions and professions. The regulatory bodies, as you might imagine, work really for the health ministries in their respective provinces or territories. And so they would be following directions of the health ministries, as well as evidence associated specifically with the provision of oral health care. So as we started to realize that practice were going to be reopening come May 2020, and then on a graduated basis sort of throughout the summer, and realized that all the jurisdictions were forming their own protocols, and the professions sometimes within each jurisdiction having a different protocol, we realized it's probably time maybe to have a national conversation. And so our office commissioned Dr. Allison's team at McGill University, Faculty of Dentistry, to do a significant review, and he'll talk about the details of that following this, of the elements that we saw as important to decision makers and policy makers in safe return to practice for the oral healthcare Canadians. And not a guideline, simply an evidence review such that there is a national consensus on the evidence that will be updated several times during the first year. And so you're seeing in front of you here, and I won't go ahead and read that out, but things you might imagine would be important to a safe return to practice in oral health care. And finishing off with the remaining pieces. And knowing again that this was going to evolve over time as the research evolved, and again, Dr. House will talk about that more in a bit, we also commissioned his team to do the update work. So once those drafts were ready, we convened a national knowledge-based review group, not an advocacy-based, but knowledge-based, with the expectation and understanding that these organizations is where, for the oral health care delivery professions, this knowledge would reside. And you'll notice there's both professional association side and the regulatory side, because both are important in this conversation. And the faculties of dentistry, there are 10 faculties of dentistry in Canada, and they have a national association. And so representatives from that group. And also, of course, from the federal health portfolio, the Public Health Agency of Canada, in particular, the infectious disease branch is obviously very important in this conversation. And over at Health Canada, the COVID-19 task force, folks from the team on workplace safety, because again, there's really two pieces to this as well. You reopen your practice, and how do you provide safe care to your patients, but also how do you provide a safe workplace at the same time in that environment. And so hats off to this group for great work in doing in-depth review of the draft that Dr. Allison's team produced, and very insightful comments. And Dr. Allison's team then rolled those in and were able to produce a final document. Now, again, big thanks to McMaster for their and the National Collaborating Center on Methods and Tools, because this is a site for early knowledge dissemination of scientific developments. And so we were able to get that up immediately. And this working group was done in English, and the original draft in English. And of course, on the federal dissemination, it will have to go through other reviews and translation, but the initial version can first go up on the McMaster website, and then on the McGill website, and then the McMaster website here points to that as a rapid dissemination of this science for policymakers and decision makers. And then, of course, once translation and the other various approvals are achieved, goes on the federal government websites and website in both official languages for access, as did and as have been, as are still, the updates to this work. So with that, I'll stop sharing and pass the floor over to Dr. Allison.
Thanks very much, James. I'm just going to share my screen. I presume everyone can see my slide, okay? You can? Great. Okay, I've got a few nods. All right. Thank you very much. First of all, thanks very much, James and your team for initiating this project, which I think is a very important project to try and accumulate the best possible evidence to support decision-making in all the groups that you were discussing. I think we all recognize that during this pandemic, it's been an incredibly difficult time for leaders of all sorts of organizations, whether it's regulatory authorities, public health agencies, hospitals, dental schools, universities, all sorts of organizations that we work with and for, because they have the responsibility of coming up with guidelines and protocols. And during this pandemic, the information available has been changing very fast, and the quality of the information is very variable. There's some very high quality information out there, and of course there's some very poor quality information out there. And people in those leadership positions have to try to make sense of that and make decisions and try to come up with guidance for their members, their colleagues, people working with them and for them in the organizations and provinces for which they have responsibility. So I think it was an excellent initiative. So thank you very much, James, again, and your office and PHAC for initiating this. I'd also like to say a big thank you to the Canadian Public Health Association for inviting us to give this presentation. We really appreciate that as well. And before I get going with the content, I really do want to give a really enormous thank you to my colleagues on this presentation and in this work. Rafael Freitas de Souza, Lilian Aboud, and Martin Morris. Of course, this was a phenomenal amount of work, and they were very, very involved in it. They've all been performing a vast quantity of work over the past year with the original report and then the updates that we've been doing. And I want to say a big, big thank you to all three of them for the different roles that they've fulfilled. Raphael has been doing a lot of the writing of the reports. Lillian's been doing a lot of the reading and the preparing of the literature ready for us to write the reports. And Martin Morris is the librarian who's been doing the searching with us. So thank you very much to all those three. So now on to the project itself. So basically, as James indicated, the idea of this was to try to identify the best quality evidence to support decision-making. The idea was not to come up with guidelines or protocols or anything like that, but to try and identify the best quality research to help the decision makers in the way that I was just describing a few minutes ago. So I'm sure you've all seen this sort of hierarchy and are aware of this sort of thing. And so we decided to focus on the top of this hierarchy to try to find the best quality evidence. And as you'll see, and you won't be surprised, in some of the fields, we were able to find very high quality evidence to support different approaches, but then in other fields, we were not. And I do want to emphasize that because we were not able to find high quality evidence, it doesn't mean that there's no evidence out there. It means that it didn't fulfill the thresholds that we decided to use to include. And that doesn't mean to say that the evidence produced in some of these fields that was not included is not good, or not appropriate. It just means it did not fulfill the threshold that we used. So I do want to emphasize this, and I understand and realize that, again, as a decision maker, then if a process like this doesn't produce enough information that you want, then you're going to probably have to go further down that evidence pyramid to try and see what else you can find to help inform your decision making. So this is the approach that we used, which is classic hierarchy of evidence. And we focused mainly on the top 4 levels here: cohort studies, randomized trials, systematic reviews, and meta-analyses of systematic reviews. So although we did adjust this as we moved along, that was broadly speaking the approach we used for most of the searches in most of the updates that we did. But we we did have to adjust it with time, and because at some of the fields we found a very high number of papers, and we felt that they were not necessarily adding to new information, so we decided to restrict even more. Whereas other fields, as I mentioned, we didn't have as much, there was nowhere near as much evidence emerging. So we felt that we needed to perhaps go a little bit further down the pyramid to try to see what we could find. But we always remained within the group of cohort studies, randomized trials, and systematic reviews and above. We agreed these search strategies with Martin, discussed them at length and went through them, and then have used them, and pretty much have used the same strategies throughout in that sense. And of course, I think you'll all be aware, and I'll show you the numbers in a minute, that the literature over the past year has been very fast changing. Lots and lots of literature emerging very, very quickly. One other comment I would say, in the first search, which was done this time last year, when we were looking for information to fulfill these topics that James showed you, we did also include similar viruses and similar diseases such as SARS, MERS, H1N1, and influenza, as we've felt that having information on these conditions and viruses was useful, particularly in the initial phases of the pandemic, when there was very little first-hand information concerning SARS-CoV-2 and COVID-19. So this is just giving a very quick overview of the numbers of papers that were identified. What you've got here, if you look across the bottom, you've got the first report, which was done, as I said, a year ago. It was released in early August 2020. Then you've got the second report, which was released in early December 2020. And then the third report, which is the far right column, which was released in April 2021. And we are currently in the process of doing the fourth report, in other words, the third update. And that will be released in late July or early August. What you're looking at here in terms of the columns is, on the left column, with the large numbers, is the numbers of papers that we identified using the strategies that I described briefly before. So first one, we identified approaching 7,900 papers. And I would indicate as well that we went, for the first report, we went back to 2000. So it went from the year 2000, January 1st, 2000, up to June 30th, 2020. For the second search, we went from July 1st to October 31st. For the third search, November 1st to February 28th. So, the period of time for the first search was much longer, but of course, the pandemic only started during that period. So there was less direct evidence. And as you can see, the smaller numbers here indicate the actual numbers of papers we include in each of these reports. So 59 in the first one, 103 in the second one, and 372. So you can see by the time we got to the report that we did in March of this year, we're starting to get into really quite, and these are just published over 3-month periods. So you can see the sheer volume of work that's being published in this area is absolutely enormous. And I'm sure most of you are aware of that fact. There's so much being published on this topic for obvious reasons. Then now, so that was the overall numbers. Now what I'm showing you here is the more specific numbers for the particular topics. I'm sorry, I've put the sort of, these are the indicators of the topics A, B, C, D, etc. I'll be going through these in a bit more detail in a minute or so. But so you've got the total on the far right, as I said, 59, 103, 372. Those were the numbers of articles included in each of our reports. As you can see, there's 2 topics which completely dominated the literature. These were the 2 first topics, which were are looking at the symptoms of people with COVID and the conditions that put people at high risk for poor outcomes for COVID. So clearly these are much more generalized. They're not specific to dentistry. So the volume of literature is much, much bigger. The other topics that you can see along the bottom, C, D, E, across to I, are much more specific to dentistry. And so the volume is much smaller. The other thing is they tend to refer much more naturally anyway to intervention studies, whereas A and B, most of the work there has been observational studies. So you can understand observational studies are relatively straightforward to do in the circumstances. Intervention studies are more complicated. So getting into the details. So this is topic A. Patients, what was the evidence concerning patients at greater risk for poor outcomes if they got COVID? Poor outcomes meaning hospitalization, getting into intensive care, or death. So here we've got some very strong evidence, as I said, and you won't be surprised. I think we're all aware of the diseases. We've heard this countless times. So our literature reviews were, of course, in line with what we're hearing everywhere in terms of the conditions that put people at higher risk of poor outcomes for COVID. And of course, this is a direct relevance to a dentist or any dental professional. They have to consider the need to see their patient based on if they've got any of these conditions, is what's the real need of their patient. So those are the diseases there. I'm not going to read through the list. As I said, I think we're all very aware of those. In terms of the non-disease areas, again, I think we all have heard about these. Particularly the increased age, with 60 years being a particular threshold where the risk really starts to increase. Smokers, pregnant women are also at increased risk of poor outcomes. Neonates of women infected with COVID-19 is emerging. But I think it's important because there was a lot of discussion around this at the beginning, pointing towards different sex or genders. And I think that while there are different rates of getting the disease in the sexes and genders, that differs by country, and it's often dominated by the fact that what roles men and women fulfill in society. So for obviously healthcare professionals tend to be at higher risk for getting the disease. So remember, this is for getting the disease, not necessarily for poor outcomes. That can affect them getting the disease, but it does not mean that they're going to be at higher risk for poor outcomes. The next one was the symptoms. And again, I think we've all seen this countless times. If you look on the column on the left, there's very strong evidence for all of these different symptoms of people who have COVID-19. And I think of particular interest to us were the olfactory and gustatory or taste impairment that is seen commonly in these sorts of patients. looking at the right-hand column, there's less evidence, but still good quality concerning a few other symptoms. So expectoration with blood, chest pain and tightness, ocular manifestations. And then there's now emerging evidence of some oral manifestations, such as irregular ulcers and blisters, and petechiae on the palate, lips, gingiva, etc. So that's beginning to emerge as well. Now, the next group, we're moving more into the sort of areas of intervention. So this was topic C, and we were looking at trying to understand the evidence to support different non-treatment measures that dental professionals could take to help reduce the risk for everyone to be infected. And so, again, I would emphasize that while the first two topics I've just described have a lot of very strong evidence, now we're moving into areas, the remaining topics, the evidence is much less strong. Nevertheless, there is some evidence to support certain approaches. So there is moderate evidence to support telehealth in certain contexts. Now, that doesn't mean to say, so this is telehealth, not necessarily teledentistry. It's telehealth, meaning in a healthcare setting, but there has been some work looking specifically at patients, dental patients. So there is some benefit to reduce COVID-19 morbidity and mortality. There's also evidence to support triage, and this has been shown to be cost-effective and accepted by both patients and health professionals. There is some evidence to support managing patients with cleft lip and palate and those with chronic pain. And the reason why I brought that, I mean, there were articles on those particular groups. That's why we highlighted that in our latest update. That doesn't mean to say it's not true for other groups as well, but the particular research that we found identified these groups. And another area that's very interesting is, of course, training for personnel, which is really important in the current circumstances. We need to be training our personnel and colleagues about all sorts of elements of this pandemic and managing it. And so telehealth and the approach, much like what we're doing as I speak, is very beneficial in that sense. There is some evidence to support limiting to urgent care only when there are high levels of disease in the local community. There's some evidence to support temperature screening with thermometers when patients come to clinics, reduce numbers of patients in the waiting room. Physical distancing, we know lots about that. Good ventilation, and no shared objects between staff and patients. There is no evidence, however, for pre-appointment COVID-19 testing. That doesn't mean to say it can't be good, but I think we all recognize that there are issues with the sensitivity and specificity of some of the tests. So there, at the moment, that's where things are. There's no evidence to support testing people before they come to the clinic. In terms of using PPE, most evidence comes from hospitals and non-dental settings. So we have to bear that in mind. There's moderate evidence indicating the most important element of PPE is the proper donning and doffing strategies. In other words, putting on the equipment and taking off the equipment. That's when contamination can occur. But we can all imagine when people get tired at the end of the day, taking it off, that's when the greatest risks of contamination can occur. And in that sense, tabs and other mechanisms to help remove PPE are very helpful. Facial mask, goggles, and masks or respirator is recommended in most situations. And then we're basically saying that if FFP3s and 2s are equivalent to N95s. And there is evidence to suggest that gowns are the best body coverage against respiratory diseases of all natures. In terms of reuse of PPE, there's very poor evidence. One review recommended not reusing PPE unless there's a shortage. Of course, this was something that was discussed a lot right at the beginning of the pandemic when there were clear shortages. I think it may be less of the case these days, but that's why we put this topic in. If necessary, one reuse can occur with ultraviolet C radiation, hydrogen peroxide vapor, and dry heat. In terms of use of aerosol generating procedures, of course, this has been a topic of enormous debate within the dental community, but also, of course, the broader healthcare community. And unfortunately, it remains unclear exactly what the situation, particularly with respect to dentistry, dental care. There simply is not good direct evidence of the use of AGPs in dental care and the risk of contamination. There's strong evidence that SARS-CoV-2 is in saliva, so there's every logic to think that the virus is in the aerosols in the offices. And it's been detected in droplets smaller than 5 micromillimeters, and can move beyond 8 meters and stay suspended for 2 hours. So we really do need to take it seriously in that respect. There's been a lot of excuse me, work to try to categorize the different procedures. The systematic review that we identified came up with this categorization that I've put here, with higher, moderate, and lower risk dental approaches, dental treatments. But these are all based on the fact that they've been recommended multiple times to reduce doing these or do not do these in certain situations. That doesn't mean to say, again, that it's based on strong evidence for each of these ones. But this is where there seems to be agreement across multiple recommendations and guidelines internationally. In terms of transmission mitigation strategies, again, very little good quality evidence concerning the benefits for mitigating COVID-19 in dental care. There's some evidence concerning strategies for bacterial infections, but we all know that that's very different from viral infections. There's been one small randomized controlled trial suggesting benefit of povidone iodine and essential oils in pre-treatment mouthwashes. There's good evidence that povidone iodine in other healthcare settings against other respiratory viruses. So it does, the evidence is beginning to emerge that povidone iodine is a good agent to be using. There's also, of course, recommendations on the use of hand scaling, hand removal of keratogenetic tooth structure, etc., and extraoral radiographs. In terms of the space ventilation strategies, again, evidence to support precise recommendations on ventilation strategies in dental care settings remains minimal and poor. There's some evidence to support the use of HEPA filters between patients, and they talk about the fact that HEPA filters result in 99.9995% of particles being retained. And then apart from that, it's really a question of recommending when you have a suspected COVID patient or COVID positive patient, that you should be using negative pressure or continuous air exchange in your operations. In terms of disinfection of surfaces, there's moderate evidence suggests disinfection of impressions and impression trays and dental prostheses with 1% sodium chloride for 1 minute to hypochlorite, sorry, to reduce SARS-CoV infectivity. There's also some evidence for the use of glutaraldehyde and iodine-containing detergents, but it's not very strong for benzalkonium and chlorhexidine. There's evidence supporting cleaning dental chairs after each patient and all other surfaces at least twice a day. So just in conclusion, there's very strong evidence from observational studies concerning symptoms in patients at high risk, but much weaker evidence for the intervention studies I talked about. Again, thank you very much to all of these concerned. Thanks very much, James, and back to you.
Marvelous. Thank you, Paul. Very much appreciated for laying that out. We'll now move into some questions for the panel. And again, the chat function is open for the audience to add questions to that. But in the meantime, I've got a few to start off with. Panelists, do you think this was a useful exercise in support of the decision makers who ensure safe oral healthcare for Canadians? And how do you think those decision makers should have been creating guidelines, particularly given the lack of evidence at the beginning of the pandemic? Who wants to start us off on that?
I'll take a stab. I think it was an excellent exercise. And I also think it was very important that it be done at a national level. So kudos to everybody who was involved, because it is an excellent resource. You know, as to evidence in decision making at the provincial and territorial level, or the sub-national level in Canada, I think that's where things start getting a bit more, or let's just say a bit messier, given the reality of each jurisdiction and its governmental, professional cultures and so on and so forth. But to have something like this, I think is key. Even though in the end, as we all knew from the beginning, and I'm sure Paul and his team appreciated this, you're going to end up with not a lot of evidence, but something is definitely better than nothing in this context.
Thanks, Carlos. And yeah, exactly right. And Paul explained it very nicely that the role was to identify the high-level evidence with the understanding that decision makers working in real time are going to have to fill in the pieces in between to create protocols for their registrants. So agree 100%. Thank you for that. Any other thoughts on that from the panelists? Walter.
So thank you very much again for inviting for this webinar. I want to echo what Carlos said, that this was very important, essential exercise, and also it's very important for us to think about and make us to reflect in some essential areas in oral health research that is missing evidence base here, that is in terms of infection prevention control, that we saw that it has a gap and a lack of knowledge in this area. That is, when you start the pandemic, everybody was trying to find the evidence and papers that supported the decisions of the dental schools and the dental office and the regulators. And this demonstrates for us that this infection prevention control is an essential area that should be in any dental school, should be take attention and teach the students from year 1 to year 4, and this should be revisited after the pandemic, because we saw how important was the infection prevention control.
Great, thanks very much, Walter. Leah?
So yes, I echo everyone's comments, and I'd really like to thank the Office of the Chief Dental Officer for showing the oral health leadership and commissioning this work, and then to work to disseminate it nationally to all stakeholders, this evidence. In the early days of the pandemic, from a dental school perspective, and like many of us sitting on many different advisory panels, we were asked to quickly try to assemble this information as quickly as possible. So, you know, it was a highly complex and a rapidly evolving situation. And we did spend an extraordinary amount of time trying to do that. But once we learned that this body of work was being assembled, we realized that we could save our energy and, refer to this as a resource. So the number of times that our program was able to refer to this resource and to refer to it as an updated resource has informed our work. And the number of times I pointed it out to others, was numerous. So I think it was a very valuable exercise. What's been interesting is, although various organizations and institutions now have the same body of evidence to work from for developing protocols and guidelines, it has been interesting to see how people have interpreted this evidence differently.
Yeah, which is part of the process. And of course, it's their privilege to do so. But yeah, thanks for that observation. Yeah, absolutely true. Moving on to another question. Canadian oral healthcare does not use national or even provincial territorial guidelines in most jurisdictions, while medicine has many to guide the care of patients with many conditions. Do you think this initiative could be the beginning of Canadian oral healthcare considering the development of national guidelines? Someone want to start us off with that?
So maybe we'll just keep going around like this. So yeah, I think you highlight something that's foundational to the modern practice of any healthcare profession or environment or clinical activity. And unfortunately in dentistry, we are woefully behind the reality of many healthcare environments in terms of the use of guidelines, whether they be clinical practice guidelines, informal terms, or sometimes even standards. I do want to point out, though, and this is picking up on what Leah said, I'm Canadian. I very much believe in Confederation. But if COVID-19 has taught us anything, is that Confederation can represent a bit of an existential threat, and that's not an overstatement. So in that sense, I think we should take that lesson and move it forward in the regulatory context, professional and educational context, to think about how do we get, provinces, territories, dental bodies more on the same page, because with respect to interpretation of evidence and how to apply it, because we're seeing an uncomfortable, this is my perspective, an uncomfortable variation in guidance across the country, which has material consequence not only for the operations of dental schools, dental faculties, but also in terms of access to dental care, which we all care so very much about, obviously. So I think we really need to take a sober look at how we do things in a confederation and move forward more strategically, ultimately to get us on more of the same page.
Thank you. Leah, do you want to jump in on that one?
Sure. So thank you. As I mentioned, we had many regulators and other institutions, working from the same body of evidence and yet developing, in some cases, quite diametrically opposite protocols and guidelines. And I think at the end of the day, the problem there is that this had left the public very confused. And a national effort to, unify some of these guidelines and protocols, I think is very important. And I think this dovetails in very, very nicely with very recently, Premier Trudeau did a briefing in terms of a recent proposal for national norms in long-term care facilities. And this just really speaks to that. I think the time and the temperature is right for such movement. I'd like to maybe take a moment to give an example at a provincial level in Nova Scotia, where I currently am. We had great provincial leadership from our chief medical officer, who recommended that the 4 oral health professions get together and provide a single document in terms of guidelines and protocols. And as the result was all 4 professions were able to contribute equally, and we all worked through the pandemic off of a single document. And I think patients were, the public, what was served very well by that. And I'd love to see that expand at a national level.
Great point. Thank you very much. And just for the folks at home, I mentioned 6 regulated professions, but not in all jurisdictions. So Nova Scotia doesn't have dental therapists as a regulated profession, and their dental assistants are regulated through their dentistry regulatory body. So just in case anyone wasn't keeping track of the numbers at home. But thank you, Elaine.
Thank you.
Walter.
Yeah, I agree with what my colleague said. That is, I think now is the exactly time that we needed to start to have this in the guidelines in the national level, and we saw that this is essential because almost every day, every week during this pandemic was different informations, different regulations between among the provinces, and I think that is the way that we treat our patients should be equal, and this information and these guidelines should be national. I think is appropriate to start.
Marvelous, thank you very much. The next one I'll direct to Paul. So there are currently no documented cases to date at this point in time of patient to provider or provider to patient transmission of SARS-CoV-2 in a Canadian oral health care facility. So Paul, would you say that the guidelines and protocols created by the various responsible bodies have been successful?
No, I wouldn't necessarily. I mean, in the sense that I don't know that we can, the fact that as far as we're aware, the infection rates within oral healthcare professional offices are very low to minimal. It does not mean that, we can't necessarily relate that to the publishing of these documents, this report and the updates. To what extent people have been reading them and using them in developing guidelines. And obviously that's within the provinces, and then to what extent the individual dental hygienists and dentists and other professionals have been actually using the guidelines, and to what extent there's variation there. I think it's very difficult to say. We don't have that evidence at the moment. That said, as many of you here and others who are listening know, there are a number of ongoing studies that we're engaged with to try and document infection rates and the use of different mitigating strategies against the pandemic in dental hygienists, in dentists, in dental schools. So we're documenting that evidence, and I think hopefully that evidence will be able to be used in the future, because I think we've come up with the work so far, but there's a lot to go forward. It's already been mentioned that Walter mentioned that the gaps in the information, the gaps in the knowledge that we have, and so there's a lot of future research that needs to be done. So we need to keep building on this. To see to what extent these sorts of guidelines are effective in guiding our different professions.
Very much appreciated. Yes, I wasn't suggesting that this particular work had a direct effect on the fact that there's been no documented cases. I was really asking about the guidelines and protocols developed at the provincial and territorial level by the responsible bodies and the relationship between those and the great success at the apparent non-transmission between patients and providers to patients in clinical or healthcare settings. So yes, Anita, thank you for that and for clarifying. So this one goes to the panel. So all the various number of changes to the practice of oral healthcare across all 6 regulated professions during the time of the pandemic. Will some or all of these changes persist following the pandemic phase of SARS-CoV-2? Carlos, can you start us off?
Yes, excellent question. I believe so, and for a variety of reasons. Let's start off with the patient. I have a hard time believing that in the next year or 2, maybe even 3, patients are going to feel comfortable walking into busy dental office waiting rooms. our culture has changed, you know, in terms of personal space, physical space, and so on. So I think that's very important to know. Now let's think about it in terms of the practitioner. I think practitioners want to remain safe. So some things are welcome. I also think that, you know, from the point of view of the delivery of care, it's, you know, to be able to demonstrate to the public and patients that you're doing everything you can to keep them safe, I think is not only, you know, appropriate. Safety is something that we need to always go beyond, above and beyond. But I think it's also from the point of view of quote unquote business. I mean, it is a signal that you need to be given. In fact, I just recently reviewed research that demonstrated that patients say that infection prevention and control is one of the most important things in their visits to the dental office, interestingly enough. And
Oh, you just froze, Carlos. Okay, we'll pick that one up a little bit. Walter, you want to carry that one on?
Sure, yeah, absolutely. I agree with Carlos that is some changes will start and will continue after the pandemic. I think one that you continue after the pandemic, and this will be the screening process for the confirmation of the patient before coming to the dental office. That is right now, I think everybody is doing a screening process where the patient has any symptoms related to COVID or flu, or we postponed the appointment. I think this is something that will continue and will be increase during the pandemic and after the pandemic. I think that also the type of mask that we are using in the clinic will change. That is, I can see that the N95 and level 3 surgical mask is probably will be the preference of the healthcare providers and the oral healthcare providers. I'm not totally sure about it because has no evidence, as Paul mentioned, about what we call AGP rooms, the aerosol generating procedure rooms. I don't know if this will continue because has no evidence of transmission. But some changes will happen, and this happened. And if we go back in the history when we have the HIV, there were some changes happening in the dental office. I think with the COVID, the same thing will happen.
Super, thank you very much. Leah?
I agree. I feel that just like in the mid-'80s when our levels of universal precautions changed dramatically and permanently moving forward, I think we'll see some sort of changes to what are become our standard universal precautions. I always want to speak grounded in the evidence, but this time I'll just speak pragmatically. I think the two things that come to mind very quickly are face shields and gowns. I think after using those now with aerosol generating procedures and seeing what the face shield looks like after an aerosol generating procedure, I don't think we'll ever go back.
Great point. Really good point. I'm going to move on to a related point. Has this evidence changed how oral health clinicians are educated in Canadian universities and colleges? You're sort of touching on that a little bit. What's changing? All of you are in educational institutions. What has changed around you as a result of this in the education of oral health clinicians? Carlos, you want to start off?
Apologies for the internet freeze, and it probably occurred at a good moment. I might have gotten myself in trouble there where I was going, but nonetheless, yeah, lots has changed. You know, we just cannot educate students as efficiently as we could in the past. And some of that, at least in my province, has to do with the regulatory guidance that's in place around enclosed operatories and aerosol generating procedures and such. So again, I really think that we need to think about what are the unintended consequences of our approaches to infection prevention and control.
Okay. Good point. Walter?
Yeah, a lot of changes happened from year 1 to year 4 in the dental school, and also in our dental assistant program. So one of the major changes was related to infection prevention control. That is, we started to teach the students from day 1 in the dental school, and this was intensified and with COVID. Other big change that we saw was in the clinic, that is because of the aerosol procedures, forehand procedures, where we have a team working in a patient. And also we saw some changes in terms of how we deliver our education content because of the COVID. All the content was provided online, the didactic lectures, and also the interaction with the professors and the students. And this is something of these changes. I am absolutely sure that this will continue after COVID.
Absolutely, Marla. Thank you very much for that. Leah?
Absolutely. So like everyone, face shields, having assistance, high volume evacuation for all AGPs, performing non-AGPs where there's an acceptable equivalent. Those are all things that have happened in our programs as well. I think I will speak more towards the didactic content that Walter alluded to. You know, we all had to very quickly shift to a online delivery format, and originally it was quick, get it up as quickly as possible. But once we had a chance to catch our breath, we actually took the time to really dig in and ensure that that online remote delivery was very pedagogically sound. And in some cases, we came to realize that there could be situations where it was actually better delivered that way than when it was face-to-face. Some of these examples were some of our SIM had to move over to virtual SIM, virtual OSCEs, those sorts of things. And although we're very much looking forward to getting back to a face-to-face learning environment, because it's very critical for many different reasons, there are a handful of different items that we will keep moving forward. So that's a little bit of a silver lining in all of this.
Indeed, everything has opportunities as well as challenges. I fully agree. CPHA, particularly Greg, has kindly advised that he'll allow us to run over a little bit because we're in hot pursuit of a number of questions, and a lot of the questions that I'm seeing on the Q&A side, I'm able to roll into the conversation, but we do need a few more minutes. The next piece, I definitely start with Carlos on this one. How have these changes in oral health care in Canada during the COVID-19 situation affected access to care? If so, how? And have any cohorts of Canadian patients been more affected by this than others? Carlos?
So we of course know that the whole population was affected, given what was effectively a significant contraction of the ability to deliver care early on. We don't have any, or at least that I know of, any direct Canadian evidence, but I'll point to two studies. My research group has been doing an analysis of claims data from a major insurer in Canada, and if you can believe it, we're still not. Well, maybe you could believe it. We're still not at the volumes of care delivered at the exact same time previous years, and so on, both in terms of claims, the volume of claims, and as well as dental care expenditure. And we seem to be heading a bit downwards. So we never reached what we were normally at, and now we're heading slightly downward. Secondly, and thank you to the Canadian Dental Association for sharing this data with a variety of groups, including me, showing that a good majority of people want to go back to the dentist, are happy to go back. Some are waiting. But ultimately, the people that are getting hit are, as always, socially and economically marginalized Canadians. And this is from the point of view of loss of jobs, loss of family income, a loss of dental benefits, although that's been relatively minor. But again, just like we see in general terms, any negative outcome with respect to access to care disproportionately affects the people that need it the most. So, you know, in the future, we'll hopefully have more information on this, but to me, those are the signals that I've seen currently.
Walter, you want to touch on that?
Yes, as Carlos said, we don't have yet any research support or evidence to say that one group was, but I guess that the immunocompromised patients was significantly affected during the pandemic, and we definitely need studies on that. I'm very happy that Carlos is doing that. That is extremely important for us to create a baseline here to creating the alternatives, because we can have other pandemic and we needed to create alternatives. And one of the alternatives must be the teledentistry. That is the teledentistry or the telehealth that Paul mentioned should work in the proper way or in the same quality as we provide the patient care when we have our patient in person in the dental office. I think this is essential research that needs to be done in this area to see what population was more affected here and why this population was affected.
Great point, thank you. Leah?
I'm just going to simply leave my comments with agreeing with Carlos and Walter's comments. These are truly, you know, is particularly in Carlos's area of expertise, and I completely defer to him.
Wonderful, thank you.
And I defer to Paul, so you're in good company.
And speaking of Paul, this next one starts off with him.
Well, if I may, James, just to
yes,
add
please.
to that, seeing as I'm being deferred to, I think, you know, again, as Carlos and Walter said, we really don't have any good evidence that for in Canada around this. But I mean, we've all heard about and read about the fact that those of us who are lucky enough to be in high-paying jobs that can be done from home have maintained our salaries and have been fine, essentially. And there are lots of people working in all sorts of different services who basically lost their job straight away. Now, they may be getting back their job at some level, or they may not be. But of course, just as Carlos was referring to, I think that, again, unfortunately, as is often the case, the pandemic hit different groups in our population in different ways. And some of us have carried on pretty much fine and have carried on earning the money that we need and can put that towards dental care if we want to, whereas lots of other parts of our population and our society don't have that privilege at all. They've lost their earnings and they're poorer off because of the pandemic, and they're less well employed because of the pandemic.
Great points. Great points, thank you. And keeping on a roll with you, Paul, the four of you are involved in the study examining occupational risks associated with SARS-CoV-2 in dental schools across Canada. Can you start off the description of that study and that work?
Sure. So as I briefly mentioned in a previous response, where all of us around this gallery are involved in one way or another in 3 studies, ongoing cohort studies, where we're investigating COVID infection rates amongst dentists in the community, dental hygienists in the community, and amongst dental schools. The one you've just referred to in dental schools, that was the latest one to start. It only started in April of this year. And so the focus is as well as we're interested in infection rates, we're also interested in understanding the immune response to vaccination as well. And I see Walter nodding and excuse the pun, salivating, because we're collecting a lot of saliva samples and blood samples from this study of students, professors, and support staff in dental schools to try and understand how they respond to vaccination, but also, you know, amongst the unfortunate few who do get infected, we want to understand the immune response of those who get infected as well. So that's a study that we'll be doing. We just started it, and we'll be doing it over the course of the next year or so. The other two studies we've been doing for a number of months now. So hopefully we'll be publishing the results of those quite soon. Have we lost James? While we wait for James to come back, Walter, do you want to comment as well and talk about the saliva side of this?
Yeah, so as you mentioned, Paul, these studies are ongoing. So we are collecting saliva monthly from dentists across Canada and from the population that serve the dental schools, that's the students, the staff, and the faculty members. And in one of the projects, that is the Dentist Across Canada, we are now entering the month number 9, and we are collecting around 250 saliva samples per month, and this is a resource of this saliva samples for us to analyze not just infection rate in the dental office, but also now with the vaccine to understand better the vaccine and in the saliva, and also to explore other opportunities we are starting to explore, and to see, for example, the level of stress by measuring cortisol in the saliva from the dentist, right? In these 9 months that we are collecting, and compare with our monthly questionnaire that is all the dentists is answer every month. So I think it is a very valid and important studies that we are doing to better understand the COVID-19 and to better understand the pandemic that is in general.
Well, thank you very much. Leah, do you want to round that one up?
So I agree with my colleagues, and not only are these studies providing us valuable information about COVID infection rates within oral healthcare professionals, as well as really important information on immunity and vaccine response. But what's particularly exciting is the possibility of assembling data on what long-term response will be to vaccine. That will be some of the first data available there. But coming back to the dental school study, not only is this going to provide information about oral healthcare professionals, but it's really well poised to provide information about large university institutions in general, in terms of devising safety guidelines for return to campus, and it has much broader and wider implications beyond just oral health. So it's a particularly exciting study.
Okay, thank you very much. Looking at the attendee Q&A, and maybe defaulting away from specific agents questions, where this is more of an overview conversation. There is a question that feeds into something we've been discussing already. Do you have any suggestions on how to address the lack of consistency on the approach of oral health across the country? Again, that one, let's start Paul off with that one.
Thank you so much. It's very difficult. I think we have to acknowledge that when there's a lack of good evidence in many fields, and now whether we're talking about the pandemic, approaches within a pandemic, or just general oral health care, there are many parts of oral health care where the evidence to support different approaches is not very strong. Of course, there are plenty where it is very strong. So I think we need to acknowledge the quality and the lack of evidence in some fields, but then we could also focus on some areas if we want to move forward in this direction. There are some areas where I believe You know, if we look at for instance, the use of fluoride, and I'm not talking about necessarily fluoride in the water supply, which of course is more controversial, but if we talk about the use of fluoride in dental offices on one-on-one use, individual use, or fissure sealants or approaches like that, there's very strong evidence to support these approaches. And I think that's a really good place to start, where I would hope there would be a very strong agreement across all of the professions and across the country, the different jurisdictions, to say, okay, we can build something around these areas where there's very strong evidence to help us preventing caries or whatever it may be. So I think I would like to think that I'm ever the optimist. I understand it's very complicated with all of the different professions and different jurisdictions, but I would hope that with us wanting to try and help the population at large, and particularly the underserved groups, that we could begin to come together and see the benefits of having a more unified approach where we have strong evidence, at least.
Ed, do you want to touch on this one from your perspective?
I agree very much with what Paul has said. I think where we're seeing variations amongst different, provincial or different jurisdictions stems from the fact of there just is a lack of evidence in that particular area, hence why people have interpreted what is available differently. So I would, as a researcher, the first thing I would say is we need more support for more research and more evidence for that. And just to look to our national leaders to start to carry this movement forward. Clearly there is an appetite. People are ready for this discussion to move forward. And I encourage everyone who is passionate about this issue to begin to get involved in this movement to see if we can get some traction on it moving forward.
Marvelous, thank you.
So I'm just going to quickly jump in here and be a bit controversial.
Yeah.
Meaning, I have seen more consistency in thought and approach among my association colleagues than I have among my regulatory colleagues. And,
so
and
you say it
ultimately,
again, I had a blip in the feed. More consistency or inconsistency?
I have seen more consistency among my association colleagues in thought and approach than in my regulatory colleagues. And ultimately, while I agree with Paul that this can be complicated, and a good place to start is where we do have evidence, and I agree with Leah that we need more evidence. In the end, to me, most problems are solved by courage and moral authority. I mean, the regulators have in their public interest mandate the ability to do this across the country. I saw in the comments earlier, viruses don't distinguish between borders, and there's no reason why this, that, and the other. I mean, to me, it's kind of simple, but I guess I'm not. That's why I don't sit in those chairs, I guess. But there's a thought for you.
Thank you, Carlos. Walter, do you want to round that one up? Oh, falling off the Saskatoon. We got a couple more pieces, I think, and then we'll finish up. Paul, we had a question that were there studies done concerning the efficacy of COVID-19 pre-screening questionnaires prior to appointments? And you touched on that in one of your slides. Do you want to expound on that a little bit?
Well, as far as I remember, there was nothing specific around that. I think the concept of screening, because it talked about some evidence to support triage, but specifically what questions to ask. I think that's where the focus would go back to what questions around symptoms, questions about risk status, that sort of thing. So sorry, I'm going to opt out by saying, unfortunately, no, there isn't particular evidence concerning particular questions, but there is emerging evidence that it is helpful to be taking that approach. And Walter referred to that as maybe a way forward going forward, that we will be thinking about screening and then thinking about how we can use telehealth when we're working with people who we've decided it wouldn't be good for them to come in tomorrow or next week, but perhaps delay for a few weeks.
Thank you, Paul. And maybe you can start us off with the last question, which from an attendee, I think is touching on that work out of Bristol that you and I were discussing earlier this week on AGP. Do you have any comments on the recent research that seems to indicate the amount of saliva in the aerosol from AGP is actually quite minimal, or the study indicates that the majority of aerosols from ultrasonic scaling procedure was consistent with clean aerosol produced from the instrument itself? Like, again, I think that's the Bristol one we were talking about earlier this week.
Right. Yes. So I mean, you know, obviously this is very helpful work to help us try to understand what's going on. But again, this is a very good example of the sort of work which is good quality research, which is helping us to understand the situation, but is not included in our review because of the nature of the design of the study. It's not designed to test a particular intervention or anything. So what we've been focusing on is what interventions work to prevent contamination. So and there just isn't the evidence out there at the moment, but that sort of evidence would be great in terms of leading to the next step, which would be to say, well, based on that understanding, what intervention would we want to test if we were going to go to a randomized trial?
Perfect. Thank you very much. Unless any other panelists want to touch on that one? Hearing and seeing that we're 15 minutes over, and our CPHA host has been very kind and patient with us, I'll thank the panelists and hand back over to Greg. Greg?
Thank you, Dr. Taylor. Thank you to all of you for presenting and discussing today. I know, other than going to a dentist or a hygienist, I have not a lot of engagement in this, and I find it very interesting that, you know, consistently across this country, that the lack of consistency in how we sort of operationalize is very intriguing. And I think just based on the comments and seeing what's going on, and so from my perspective at CPHA, it's really interesting to see what's happening in this field. Even though I know Dr. Taylor is part of the public health agency, it is an area within public health that probably doesn't get as much recognition. So I really appreciate this topic and all of you for presenting and for spending the extra time to cover off this. So thank you to all of you. And with that, I'll wish all of you and the participants a good day.
Thank you very much.
Much.
Bye.